So the today's topic of discussion is drugs affecting blood and blood formation. Particularly, these drugs are used in condition of anemia, whereas supplements are used for the treatment, such as iron, vitamin B12, folic acid, erythropoietin. So today we will focus only on the iron part of the supplements. So these are called as hematinics. The term hematinics is referred as formation of hemoglobin in the blood. Hemoglobin is the protein found in the RBCs that carries oxygen throughout the body. They carries oxygen, then supply those oxygen molecules to the tissue or the nearby cells, and then carry deoxygenated carbon dioxide and thus make the deoxygenated blood carriers. Anemia is a condition where a person does not have enough healthy red blood cells. You can see in the picture, normal count of the RBCs is in proportion, whereas in the anemic condition, count of the RBCs is less. So hematinic includes various nutrients and compounds that play a crucial role in the production and maintenance of healthy red blood cells, such as iron, vitamin B12, and folic acid. Why anemia occurs? So there is imbalance between the production and destruction of RBCs. Body produces RBCs and then excretes them. So in between those two processes, there is always balance is made. So wherever there is imbalance between production and destruction of RBCs, anemia occurs. So there are three basic reasons: blood loss, impaired red cell formation, increased destruction of RBCs. ब्लड लॉस मतलब अगर एक्यूट और क्रोनिक ब्लड लॉस हो गया है बॉडी से इन केस ऑफ एक्सीडेंट और एनी इमरजेंसी कंडीशंस लाइक दैट. सेकंड, impaired red cell formation ड्यू टू डिफिशियंसी ऑफ इसेंशियल फैक्टर्स. मतलब रेड सेल फॉर्मेशन में कुछ डिफिशियंसी आ रही है विटामिन की वजह से, या फिर बोन मैरो डिप्रेशन हो गया है, उसको हाइपोप्लास्टिक एनीमिया भी बोलते हैं. एरिथ्रोपोइटिन डिफिशियंसी हो गई है. एरिथ्रोपोइटिन इज अ hormone which secretes and then synthesis of RBCs has been initiated. Increased destruction of RBCs. अगर RBCs का डिस्ट्रक्शन ज़्यादा हो रहा है बॉडी से तो RBC काउंट घट सकता है. उसको हिमोलाइटिक अनेमिया कंडीशन को बोलते हैं. यहाँ पे पूरा प्रोसेस बताया है. लो ब्लड ऑक्सीजन मतलब ऑक्सीजन में अगर ब्लड में अगर ऑक्सीजन कम पाया जाए तो लीवर और किडनी दोनों इरिथ्रोपोइटिन नामक हार्मोन सिक्रेट करते हैं जो ब्लड में आता है. उसके बाद रेड बोन मैरो को सिग्नल मिलता है फॉर द प्रोडक्शन ऑफ सिंथेसिस ऑफ आरबीसीज. देन देयर आर इंक्रीज नंबर ऑफ आरबीसीज एंड दैट कम इनटू ब्लड स्ट्रीम. सो एंड इंक्रीज ऑक्सीजन कैपेसिटी जब हो जाता है तब उसको इनिबिशन का सिग्नल मिलता है. तब तब इरिथ्रोपोइटिन का सिंथेसिस कम हो जाता है. नेक्स्ट स्लाइड इज, so we will there are various types of anemia, but we will today focus on iron deficiency anemia, which is caused by insufficient iron to produce hemoglobin. In iron we will see distribution of iron in the body, what are daily requirements, iron absorption, transport, utilization, storage and excretion, then its preparations and dose, uses, and acute iron poisoning. So introduction: in ancient times lahu bhasma was being used for the various anemic conditions. After that, in the early 19th century, Blot developed his famous Blot pill consisting of ferrous sulfate and potassium carbonate for anemia. So distribution of iron in the body: total body iron is in an adult is 2.5 to 5 gram, average is 3.5 gram. मेन में ज़्यादा होता है 50 mg per kg as compared to women, that is 38 mg per kg. So hemoglobin carries 4 molecules of iron. So it has total 0.33% of iron. Iron is stored in ferric form only in combination with large protein called as apoferritin. Apoferritin plus ferrous is equal to ferritin and hemosiderin. So red blood cells carry iron, then it get released into the cell of the uh, cell. Then it it being used for the various cellular functions, and जो remained है वो ferritin और hemosiderin इसके पैरेलल में वो सेव होता है. ferritin is a storage form of iron, एंड सर्कुलेशन में ट्रांसफेरिन उसको सर्कुलेशन में लाता है, वो Fe3 करके सर्कुलेशन में रहता है. Fe3 form of iron. Then daily requirements of iron according to body type. You can see adult 0.5 to 1 mg, adult female 1 to 2 mg. Obviously more in adult female because of the menstruation cycle per month. Infants 60 microgram per kg, children 25 microgram per kg. Then pregnancy, it is the highest demand, that is 3.3 to 5 mg, and in last 2 trimester the demand increases. Dietary sources of iron. There are three types of sources of iron, like rich, medium, and poor. Rich includes liver, egg yolk, oyster, dry beans, dry fruits, wheat germ, yeast. Medium involves meat, chicken, fish, spinach, banana, apple. While poor, milk and its products, root vegetables are also the source of iron. Absorption of iron. So daily diet intake of iron is 10 to 20 mg. Then they are absorbed all over the intestine. Mainly upper part of the intestine is involved in the absorption of iron. Two forms of iron are there: inorganic and heme. Absorption is high for heme, that is 35%, because it doesn't require carrier, and inorganic iron up to 5%. But the concentration of inorganic iron is the highest. Okay, so inorganic iron, ferric for better absorption converts into ferrous. So inorganic iron का ferric जो form है वो better absorption के लिए ferrous form में convert होता है. And there are two gates of iron absorption, DMT1 and FP. DMT1 luminal membrane पे रहता है. It is full form is divalent metal transporter and carries ferrous into cell. ये ferrous जो है उसको वो cell में entry देता है. FP iron release from heme is transported. Factors increasing absorption of iron in the body. So कौन से factors ऐसे हैं जो absorption of iron in the body increase करते हैं, like acid reducing substances and meat. मीट क्योंकि acid secretion increase करता है, so that's why acidic favors dissolution and reduction in ferric form. Reducing substances like reducing मतलब जो ferric iron को फॉर्म ऐसा फॉर्म में लाते हैं जो ऑब्जर्वेबल है, दैट इज फेरस. सो उसमें ascorbic acid and amino acids, mainly that's SH groups of there. Then factors impeding absorption of iron in the body. So alkalis, basically alkali environment में iron soluble form produce नहीं होगा, तो फिर alkali decrease करेगा iron absorption in the body. And then there are complexing agents that forms complex with the iron, like phosphates, for example in egg yolk, phytates, wheat and maize में जो होता है tetracyclines, they form complex with the iron and make absorption of iron in the body difficult. Presence of other food in the stomach that delays the absorption of iron in the body. So this is dietary iron. It comes in two forms: inorganic Fe+3 and heme. Heme get absorbed directly into the cell, and then Fe3 convert into Fe+2 in presence of acid and reducing agents that get absorbed by with the help of divalent metal transporter receptor into the mucosal cell. Then it get converted into ferric form and stored as a ferritin. Then this ferrous with the help of Fp receptor comes into the plasma. Heme convert into Fe form, ferrous form get with the help of Fp receptor get into the plasma. Okay, and this is receptor transferrin. With the help of transferrin, it goes into endothelial cells of organs like kidney and spleen, liver. Okay. Then there is concept called mucosal block. So mucosal block में क्या रहता है? Refers to a mechanism in our intestine where the cells lining the gut regulate how much iron get absorbed into our bloodstream. So we can see there is a sequestration of ferritin. मतलब जब भी बॉडी में आयरन का कॉन्सेंट्रेशन ज़्यादा बढ़ जाता है और सारे रिसेप्टर्स जो है वो फुल हो जाते हैं, लाइक DMT1, डाई डाइवेलेंट मेटल ट्रांसपोर्टर, वो फुल हो जाते हैं. ओके. देन देर इज IRP, ये इसको ब्लॉक कर देता है फेरेटिन को. सो उसका कॉन्सेंट्रेशन सेल में बढ़ता नहीं है, उसको कहते हैं म्यूकोजल ब्लॉक, विच इज वेरी नेसेसरी बिकॉज सेल में टॉक्सिसिटी बढ़ना चाहिए आयरन कॉन्सेंट्रेशन की वजह से. So these cells have special receptors and mechanism to control the amount of iron that passes through them. So there are preparations, oral preparations, iron preparations, and parenteral preparations. We will see oral iron. This is preferred route of administration. Sustained release आयरन काम में नहीं आएगा क्योंकि जो ओरल से हम लेंगे आयरन वो इंटेस्टाइन में जाके ही एब्जॉर्ब होगा. ओके. सो सस्टेन मतलब बहुत देर तक रिलीज ना होके बाद में रिलीज होगा तो उसका इफेक्ट भी बाद में ही मिलेगा, जो इररिलेवेंट है, इरैशनल है वो. ऐसे ही उसको ओरली लेने के बाद वो देर से ही एब्जॉर्ब होगा. सो इट्स नॉट रिकमेंडेड और इट्स नॉट रैशनल टू यूज. ओके. बायोअवेलेबिलिटी भी उसका ज़्यादा नहीं है, वेरिएबल है. एंड लिक्विड फॉर्मुलेशंस, लिक्विड ओरल फॉर्मुलेशंस may stain the teeth, so they should be put on the back of the tongue and then swallowed. In general they are less satisfactory because of the coloration in teeth. Then there are various formulations. Salts of iron use sulfates, fumarates, gluconate. These are the salts with their various concentration and brand names. So इसका feature क्या है? Ferrous salts are inexpensive, have high iron content and better absorbability. Then carbonyl ions. Carbonyl ions are absorbed from intestine over a long time and gastric tolerance may be better. So gastric tolerance जो है वो कार्बोनिल ग्रुप से ज़्यादा आता है, इसलिए कार्बोनिल आयरन 100 mg आयरन देते हैं. उसका ब्रांड नेम फेरिका कैप एंड HB फास्ट कैप. The brand names are Mumford syrup, Polyron tab, Piper tab, Polyper chewable tab. These are claimed to be better absorbed and are produce less bowel upset. They are generally, but they are generally more expensive. Ferrous ammonium citrate. These are available in 60 mg iron and 160 mg. Brand names are Probopex and Dexorange cap syrup 15 ml. Adverse effect of oral iron preparation. So there are constipation and diarrhea are the common because of the acid infection of iron, also by alteration of intestinal flora. Others include epigastric pain, heartburn, nausea, vomiting, bloating, staining of teeth, metallic taste, leak. Tolerance. The tolerance of iron preparations, oral iron preparations are improved by initiating therapy at low dose and then gradually escalating to the optimum dose. Parenteral iron therapy by injection is indicated only when. So there are conditions when parenteral iron treatment is indicated. If oral iron is not tolerated, bowel upset is too much in patient, then there are recommendations to use parenteral iron. Failure to absorb oral iron for with various conditions like decrease in iron absorption, malabsorption, inflammatory bowel disease, chronic inflammation. In these conditions, there is failure to absorb oral iron. Then parenteral iron is recommended. non-compliance to oral iron, various reasons as per individual health, severe deficiency, like in chronic bleeding, you have to put patient on a parental iron, along with erythropoietin. If erythropoietin treatment is ongoing, then demands of rapid to meet the demands of induced rapid erythropoiesis, parental iron is given. So there are four formulations. Basic old formulations are iron dextran and iron sorbitol citrate, which have been used over 50 years now, and then new formulations like ferrous sucrose and ferric carboxymaltose, less risky and have improved ease of administration. So that's why they are used. So three are compared: iron sorbitol citric acid, ferrous sucrose, ferric carboxymaltose. So iron sorbitol citric acid is low molecular weight, given by intramuscular route. 30% excretion happens in urine. So after some time, after the administration of iron sorbitol acid, the color of urine of patient turns into brown. Binding with the receptor transferrin hence get saturated. So it get transferred to the through the receptor. So it gets saturated, and the remainder which is not into the cell, that is highly toxic. So IV is not preferred route, because अगर IV से देंगे तो धीरे 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 concentration of highly toxic ferric जो सेल में नहीं जा पा रहा है because of the saturation of the receptor, टॉक्सिसिटी बढ़ेगा ब्लड में. एंड ब्रांड नेम इज फेरीमैक्स 75 mg. ferrous sucrose second drug, it is high molecular weight, given by IV 100 mg. It is cannot be given by IM and subcutaneous due to high alkalinity. Oral iron should not be given concurrently until 5 days after last injection. So after giving the ferric sulfate, you cannot recommend oral iron or कॉन्करेंटली नहीं देख सकते, और 5 days आफ्टर द लास्ट इंजेक्शन नहीं दे सकते. ब्रांड नेम्स यूनिफेरॉन, आइकोर, माइक्रो, ferric carboxymaltose. It is that ferric hydroxide core is stabilized by the carbohydrate shell. Daily 100 mg up to 1000 mg in 100 ml saline solution is recommended by IV route. It is also not injected by IM. The lack of safety data, because it's the new drug, lack of safety data is there, so it is not given below 14 years. Brand name is Insicav injection. Adverse effect of parental oral, local pain at the injection site is a common, pigmentation of skin, sterile abscesses, especially old and debilitated patient, systemic fever, headache, joint pains, and vascular collapse and death occur rarely. Use of iron deficiency anemia. Iron should normally be administered orally. Parental therapy is to be reserved for special circumstances that we have seen. A rise in HB level by 0.5 to 1 gram DL per week is an optimum response to iron therapy. मतलब अगर एनेमिक पेशेंट है और उसका एच बी 0.5 to 1 ग्राम पर डीएल बढ़ रहा है पर वीक, that is the optimum response. Your treatment is going well. Okay, it is faster in the beginning and when anemia is severe. Later the rate increase in HB declines. Uses of iron, प्रोफाइलेक्सिस यूज भी कर सकते हैं. मतलब प्रेग्नेंट लेडी आयरन डिफिशियंसी होने के पहले ही उनको प्रोफाइलेक्टिक मेजर्स के साथ सप्लीमेंट्स ऑफ आयरन प्रोवाइड किए जाते हैं. The amount of iron available from average diet and absorptive process in the intestine plays a ceiling on iron absorption of 3 mg per day. Menstruating, lactating, acute blood loss, other related conditions, it is recommended. देन मेगालोब्लास्टिक एनीमिया में यूज होता है. पर्टिकुलरली मेगालोब्लास्टिक एनीमिया में विटामिन B12 की डिफिशियंसी है, फोलेट थेरेपी देते हैं. पर उससे भी अगर आयरन डिफिशियंसी ज़्यादा दिख रही है, मे बी अनमास्क, So iron status of this patient should be evaluated and iron given accordingly. Then there is acute iron poisoning, occurs mostly in infants and children. If 10 to 20 iron tablets are consumed accidentally or equivalent liquid preparations are consumed, then they may cause serious toxicity in them. It is very rare, but what are the pathological conditions or the symptoms? Hemorrhage and inflammation in the gut, hepatic necrosis, and brain damage may happen. ट्रीटमेंट के दो अप्रोच है टू प्रिवेंट फर्दर एब्जॉर्प्शन ऑफ आयरन फ्रॉम द गट. तो उसके लिए वोमिटिंग इज द फर्स्ट मेजर और गैस्ट्रिक लैवेज विद सोडियम बाइकार्बोनेट. जो अल्कलिनिटी बढ़ेगा तो आयरन इनसॉल्युबल होगा. ओके, गिव एग yolk and milk orally to complex iron. Activated charcoal does not absorb iron. Activated charcoal is given in various metal poisoning conditions. So activated charcoal in this case does not absorb iron. Then second approach is to bind and remove iron already absorbed. So desoferoxamine is the drug of choice. It is injected intramuscularly, then repeated 4 to 12 hours as required, or IV 10 to 15 mg per kg per hour, maximum 75 mg per kg in a day till serum iron falls below 300 microgram per dl. Early therapy with desferoxamine has drastically reduced mortality of iron poisoning because so that's why it is the drug of choice. Then, alternatively, DTPA or calcium pyridate may be used if desoferoxamine is not right. BAL is contraindicated because its iron chelate is also toxic. So, what is BAL? BAL is dimercaprol, or it is called as British anti-leviside. This is the most common used drug for metal poisoning, but it does not chelate or form complex that is um, that is very highly toxic complex it forms, and toxicity uh, may worsen due to the BAL. So other supporting measures for the acute iron poisoning are fluid and electrolyte balance should be maintained and acidosis corrected by appropriate IV infusions. Diazepam should be consciously used to control convulsions if they occur. Okay, so this is all about the hematinics and iron part of the drugs affecting blood and blood formation. Reference of this all the information is very book. K.D. Tripathi, Essentials of Medical Pharmacology.